I'm not sure, of course, given your earlier discussion and given the title Beyond Health Financing, exactly the drift, but I don't want to go beyond health financing because I believe health financing is actually the central issue for poor people. The problem's money and how to mobilize it and then how to use it properly. And I just want to say a few words about 2015 and to say a few words about the post-2015 universal health coverage agenda. I'll start back maybe in 2000 with the Millennium Development Goal period and just a little bit of a reflection on what's happened. I think of all of the aspects of the Millennium Development Goals, the public health goals, MDGs 4, 5, and 6, were the most successful, and they were the ones that were the best financed in relative terms with the scale of, and the public health community distinguished itself by showing that with more resources, more could be done. This was the premise going into 2000. It was the premise of a commission that I led for WHO in 2000, 2001, the Macroeconomics and Health Commission. It was the premise that many of us pushed when we helped work with Kofi Annan to design the Global Fund and get that started, and then PEPFAR, PMI, and many other initiatives, that with more resources, more would be accomplished. And I think that public health proved itself as a rigorous, science-based discipline. I don't think we need all that much more evidence, frankly. I think we just need good, constant operations, research, and monitoring and evaluation. I don't think we need more tests. The test community is driving us all a little bit crazy. By the way, you don't need randomized trials to learn things. You watch, you study, you measure, you find out, you report, you accurately count the data. You learn a lot, by the way. So back in 2000, there was not only the mass epidemics of AIDS, TB, MDR TB, and malaria running completely out of control, there was a lot of skepticism about whether more money would make a difference. And you know, every time I opened my mouth, I asked for more money for health. And so people complained, and oh, it's not money, Mr. Sachs, it's not this, it's not that. That's a bunch of baloney, by the way. Poor people don't have enough resources. That's what poverty is. And when countries are poor, governments don't have enough resources. Sorry, it's simple. And if you're a country at $400 or $500 per capita, just do the arithmetic. You collect 20% of GDP in government revenues times, say, 400. If you're a low-income country in Africa, that's $80 per capita for all government outlays. And then if you follow the Abuja targets of 15% going to health, because really you do have education, roads, water, power, public administration, courts, police. Now, government costs money. And if you take the 15% Abuja target, 15% of 80 is $12. And you can't run a health system on $12 public funding. It's so basic, but everybody wants a different way around that arithmetic. And there is no other way around it. The World Bank pretended for a long time you could run a public health system on $12. That was the 1993 report. Yeah, if your public health system is immunizations, full stop, or maybe ORS and immunizations, then you have it. But that's not a health system. So if you actually add up what the health system costs, these days, $60 to $100 per capita, I would say. When we ran the Commission on Macroeconomics and Health in 2002, we said $34 in around 2008 to 10, and it would rise over time. But now with new prices, inflation, and all the rest, I'd guess you require 60 to 100 bucks per capita. Poor countries can't afford that on their own. So there are two choices. One is lecture to them about evidence and using their resources right and so forth and watch people die, or help fill the financing gap. Or you try to collect money from poor people, and how many more economist articles do we need that there's a downward sloping demand curve? And if you put a price on health, you rule out half the community. It happens to be the poor part. There was a new study in Science this week. It is Science, right, not Nature, the cover story of, yeah, okay, I haven't read it except I just read the conclusion. It said, economists have discovered that it's good to charge zero prices if you want everyone to get the service. Oh my God, that's wonderful. What a science. It's true, by the way. That is the right conclusion. And we knew that 15 years ago. We knew that in any civilized country that could afford it, that that was a choice, so you don't charge for immunizations. I was engaged 7 years in a battle of not charging for bed nets, and so on. So this time the money came in 2000, 2001, 2002. It's a great story. Sometime it will be written up, why the money came, how the money came. But the Global Fund got started, and the United States subscribed, and of course Bill Gates made a huge difference, and Norway made a great difference, and other governments joined in, and other actors and the governments and the pharmaceutical industry made a big difference by segmenting the market on pricing, tiered pricing, and big innovations arrived one after another, especially the mobile phone arrived to poor areas, and then early mobile phone support for community workers, and now smartphone support for community workers. The situation is so much better than it was in 2000 in terms of what can be done. But a weird thing happened if you want to understand the dynamics. The dynamics basically were we were on an ascending course up to about 2008. And George W. Bush, President George W. Bush, I should say, said in 2002 to us in discussions about PEPFAR and the Global Fund, I won't let money stand in the way. You show that it can work, the money will be there. It's the right attitude, because the amounts of money we're talking about are fractions of 1% of rich world income. So tiny that you'd never notice it. And indeed, to just give you the literal number, we probably need $40 to $50 billion a year for health, but good, clean public health money. And that would be 1/10 of 1% of donor GDP. So 1/7 of the promised 0.7. But what happened? Starting in 2008, the curve flattened out. The Obama administration decided in 2009, we're not going with that upward slope. I watched it inside OMB. Very painful. Zeke Emanuel played a role, said, we can't go on treating everyone with AIDS. Why not? Where'd that come from? We have to level off the curve. This was really a failure of nerve and of policy, in my opinion. And since there was a bipartisan support in the US Congress, it could have been done differently. But this leveled off, and we paid a price for this. Of course, the US isn't the only actor, but that big, steep ascent in public health basically leveled off after 2009. And we've been playing a catch-up game. The whole reorganization of the Global Fund was essentially turning it from a demand-driven organization to a supply-driven organization. The beauty of the Global Fund for a few years was if you had a program and it could pass technical muster, you had a pretty good chance of getting it funded, because if you didn't get it funded, I and others would yell, why isn't this decent program getting funded? And the principle of the fund was you fund good programs. Now the Global Fund has gone to the traditional, your country X, you have a certain amount of money, and use it well. That's the donor cap approach. It's demotivating, by the way. And you do it because you don't want things, quote, getting out of control. But nothing was getting out of control, just more people were getting treated. Okay, anyway, enough complaining. It's late in the day. So the truth is we kind of leveled off. And we can't level off because we have work to do. And we already proved the principle. Public health is our best operations science for saving lives. It's a wonderful science. I recommend it to everybody. I recommend it to all my students. I recommend it to anyone that asks me, what should I do in sustainable development? I say public health is a fantastic field because it really works, by the way. It's no joke. It's just very effective population scale health delivery. But it needs resources. That's obvious. So we need, by next year, to get back on real resources and real delivery mechanisms. And essentially, we need to understand that for the low-income countries, we need to get back on an upward trajectory. Now, I'll tell you a story about Ebola. A year ago, as part of the 1 million community health worker campaign, I put up a kind of advertisement to ministries of health. I don't know how long I have. I probably am way over my board. Sorry. I'll stop shortly because I could go on for hours, but mainly ranting. We put up an ad. If you want to have community health workers join the campaign, and Professor Sachs will help you mobilize the financing. So we did that, and who came forward? Basically first, right, Ann? With probably one of the most detailed plans was Liberia. And Liberia had a wonderful plan. I thought, here's a poor, small population country. It's some $10 to $20 million they were looking for. Of course, we'll get that one going. And have I completely lost my touch? I can't raise any money anymore? And so I called Mark Dybel and I called Seth Berkley, and nobody had a penny for Liberia. Oh, that's really nice, but it doesn't fit this cycle. No, we're not, the IDA's that's all done. No, we've got a certain vaccine thing. You could not fund the community health workers for Liberia when the government was asking for a coherent rural community health worker program. Okay, then of course comes this horrific epidemic. There is no structure in a lot of places. The government gets berated that it doesn't have a health system. And we're scrambling with $1 billion now promised. I'll see it when I believe it, but anyway, $1 billion. We need outreach workers, we need community workers and so forth. What kind of world is this? There should be a basic principle. Everybody should have access to basic primary health care. This isn't a radical idea. It's an old, boring idea. But we don't implement it. So I watched that one very close up. We're trying to mobilize now exactly these teams, use the technologies. And Lou here, who is a wizard on getting smartphones effectively into the hands of community health workers, is leading our effort in Guinea. And we're going to do it right now. But after the epidemic has broken out, and now there's some money on the table. But it's absurd that we operate this way, truly. So next year, there will be a sustainable development goal. that essentially will be a health for all goal. This is clear. And essentially,